Great, thanks very much. So we'll get started with an introduction. I'll ask, there's a number of people on Zoom. I'll ask if you could just take a moment now to make sure your microphones and videos are muted. There's a bit of background noise coming through. Appreciate that. And if our speaker, feel free to stop and call people out if you need a little more muting during the presentation. It's almost inevitable. So I'm Marshall Dahl, and the head of the UBC and PhD divisions of endocrinology. Before introducing our speaker, I'd certainly like to make acknowledgement that we're gathered and are grateful to both live, work, play, and study on traditional, ancestral, and ceded territories of three Coast Salish peoples, the Squamish, Tsleil-Waututh, and Musqueam nations. And we ask everyone to reflect on that. There'll be people joining often from across British Columbia and other traditional First Nations land, and ask you to think about that as well. This is a kind of a nice occasion for us because we have a special lecture series, and I'd like to pay tribute to the originator of that, who's Dr. Martin Hoffman. Dr. Hoffman was an amazing physician, internist, and endocrinologist before he was a recognized Royal College specialty. His dates are 1916 to 1983. He was responsible for things like the first diabetes education centers in British Columbia. He was a master physician in terms of diagnostic skills, in terms of academics, and was very valued. And at his kind bequest, left an annual lectureship, Hoffman Lectures, for lectures within endocrinology. So it's our custom usually to invite a speaker, and working pretty hard. So in addition to Dr. Campbell working last night to talk to the pediatric endocrinologist, and today for grand rounds, there'll be an evening lecture tonight and an academic half day tomorrow. So just as always, like to acknowledge the kind bequest of Dr. Hoffman. Moving on for an introduction, it's really a pleasure to welcome Dr. David Campbell. He's an internal medicine specialist with training in endocrinology, metabolism, advanced research training, health sciences research, has degrees in kinesiology, anthropology of health and illness, MD, PhD in community health services, University of Calgary, postdoctoral research training at the MAP Center for Urban Health Solutions at St. Michael's Hospital in Toronto, an area of research in social disparities and their impacts on clinical outcomes and metabolic diseases such as diabetes, obesity, hypertension, extensive experience with mixed methods and participatory patient-oriented research, current research program focusing on the development of novel interventions to improve the care outcomes for socially disadvantaged populations with diabetes, and presented in conjunction with the Calgary Diabetes Advocacy Committee. So the topic today is low-lived experiences of people with diabetes who have been homeless. So please join me in welcoming Dr. Campbell. Thank you.
Thank you very much for the invitation to be here with you. It's a pleasure. Just hoping to be able to get my slides up here. So I will do my own land acknowledgement to recognize that me and my colleagues here today are coming to you from Calgary, which in the Blackfoot language is called Mokinstis, which is the traditional gathering place for the people from Treaty 7 region of southern Alberta, which includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda Nations, including the Chiniki, Bearspaw, and Goodstoney First Nations. And the city of Calgary is also home to the Métis Nation of Alberta Districts 5 and 6, and I was personally born in Calgary and spent not all, but most of my life there, and I'm privileged to be a settler on that land and be able to share that land and to work there. And the work that I'm here to share with you today has been conducted largely in the city of Calgary as well. So I just like to, the predominant part of the presentation today is actually watching a movie. So if you thought you were just coming to listen to a boring grand rounds talk, well, lucky for you, you actually get to watch a movie. I remember when I was, in high school, you'd love when a substitute teacher would come and just put the movie on for you. So that's largely what you're going to get today. But before I get to the movie, I like to give a little bit in terms of setting the stage so you know what you're about to see. As Dr. Dahl mentioned, my research program is largely participatory and community-based. And what that means is I do a different kind of research. A lot of people that work in health research do work on this end of the spectrum. We do work on people. Sometimes we take their blood samples, sometimes we take their urine samples, and we study those. Sometimes we intervene on them, we give them drugs, we do surgeries on them, and then we see what outcomes they have. And all of that kind of research is important, and I do some of that work as well. But the work that I really love to do is work that's done at the other end of this spectrum. And that is facilitating research that is not done on community members, but is done by community members. So what that means is that they are not the participants in the study, they're also co-researchers is what we call them. And so we enable people with lived experience, relevant lived experience, to set the research agenda, to determine the research methods, to undertake the research and data collection, data analysis, and help us with the knowledge mobilization. So they're really involved in every facet the same way a PhD student would be in a traditional lab or a postdoctoral fellow. But these are people that are generally lay people without formalized research training. And in my setting, these are all people with lived experience of both diabetes and homelessness. And our group is called the Calgary Diabetes Advocacy Committee. We've been meeting together since 2021, so we're coming up on 4 years in existence. And our group is made up of my research staff. So today I have Tucker with me. Tucker's my master's student who's been working with my team for a couple of years. I have a few other research staff that work with us, but largely the people in the group are people like my friend Jeremy here, who is one of our community co-researchers. And Jeremy's been with us for almost 3 years now. We do work together, and essentially 2 years ago, we went to the group with this question. We said, what would make it easier for people who are experiencing homelessness to manage their diabetes in that context and in that setting? And they told us a lot of things. I mean, there are many, many things in the list of challenges or barriers that people face. But the preeminent one, when people voted and ranked and sorted their priorities, was that they really wished that there was an enhanced awareness of the challenges that they face, and that more people in the general public, but also including their healthcare providers and the people that work in homeless shelters, would have a better understanding of the day-to-day challenges that they face. And so that was what they wanted to work on. So we said, great, let's work on that together. And we did a number of projects. We first started out with a qualitative study doing interviews with shelter staff in the city of Calgary to understand what they knew about diabetes and how they helped their clients manage their diabetes. And essentially what we found is that they didn't know anything. There's very little policy that was supportive towards diabetes management in homeless shelters. But we found that the shelters wanted more. They wanted more supports. They were very keen and wanted to learn more how they could support their clients better because they'd all seen it. They'd all had firsthand experience of having somebody have a low or a high or asking for insulin and feeling unequipped and unprepared for how to deal with that. We also talked to our group and others with lived experience and heard that really the predominant experience that they had was one of stigma, that they often felt that because people didn't have an understanding or a knowledge of their situation, and the natural human tendency is when we don't know something, we fill it in. And oftentimes that's filled in with stereotypes and prejudice. And that resulted in a number of very poor outcomes for people. And finally, they wanted to share these experiences broadly. And so we actually put on a theater production. And you can see in several of these instances, you can see our co-researchers acting in a theater production. We did one for the community, so in the inner city for people that worked in the homeless serving sector, and we did one for the first-year medical students. And they were both very successful and well-received. But they were also tremendously labor intensive and not easy to bring on the road to a place like this. We'd have to bring our whole cast and crew, and that wasn't possible. So we said, well, what if we made this into a movie? And the group loved the idea, and we said, okay, let's make a movie. And I had no prior experience making a movie, but we found a grant and a film production company to partner with us to make a movie. And that's where the genesis of Low came from. So I like to give that as a preface to basically say that the movie you're about to see is in many ways portrayed as a fiction. It's not a documentary. It's portrayed as a fictional narrative film. And you'll meet the main character named Bobby. But as you watch it, I want you to realize this is not actually a fictional story. These are real stories that are told as if this was a fictional story. So these are stories that came from Jeremy and his colleagues on the CDAC. And also, it is largely centered around the experiences people have in shelters. But I want you, I know you're all physicians and healthcare workers here in the hospital. I want you to think, I know St. Paul's has a mandate to serve many of these clients, just like my hospital does in Calgary and St. Mike's where I trained in Toronto. So you encounter folks that have this lived experience probably on a daily basis. And so I want you, as you watch this, not to necessarily think about that's in the shelter, but think about how the themes that are represented may apply in your own clinical practice. So without further ado, I will start the film. It's only a short movie, so you're not stuck here all day either. That's the best part too. So it's even better than the substitute putting on a 2-hour boring movie. So it's only 38 minutes. And afterwards, Jeremy will come up and you'll have a chance to ask Jeremy any questions that you may have that linger. And we find a lot of times audiences like to have that opportunity to interact with people whose story is being told. So I hope you enjoy the film. And see if I can full screen this. Oh, no. I may need some technical assistance here. It's playing on this screen. I don't know how to move it onto the other one. And there. Yep. Yeah. Great. Excellent. Thanks.
Annika. Oh, 911.
Yeah. 911, what's your emergency?
We've had an overdose,
Hey, cowboy.
a drug poisoning incident.
Hey, buddy.
It's a client at Sunny Hill Shelter.
Okay, ma'am. Are you with the client?
Yeah, we're by the front doors.
Is the client conscious?
Not conscious. 122.
No, he's not conscious.
Is he
And he's
breathing?
not breathing.
He's not breathing. We're giving him CPR.
Okay. Is anyone harmed or is there a weapon involved?
No. We're giving him naloxone. We think it was fentanyl.
Okay, we have paramedics responding right now.
Okay, thank you.
They'll be there shortly.
Okay.
Please stay on the line with me until they arrive, okay?
Okay.
And he hits him in the head with a clock and it says, your time is up. Hey, Kev, we have to do that every time. I just love spending time with you. Oh, Kevin.
Okay, Smiley. You're all set.
Have a good one, Smiley.
Did I get some clothes?
Yeah, check with Claire in the back.
Where? Hey, you girl.
Yeah.
Annika.
You girl.
Again?
Shout and rub. Sorry, check breathing, shout and rub. Radio for help. Naloxone. 911 CPR until paramedics arrive. So that was tough.
Happens every day. Sometimes twice. You didn't have many of those back at Westdale?
Smaller shelter, mostly families.
Hey, Bug.
Hey, Kevin,
How's it hanging?
can I get my insulin?
Sure. Just back in a sec. Hey. Hey, Annika, check his bag.
Bobby, Carter.
You bet. Let me get you signed in, Bobby. Welcome.
Can I get my insulin?
Yeah, just one sec. Sunny Hill Emergency Shelter. Oh, hey. Yeah, the ambulance just left. You're good. Bobby, head on in.
Come on, Bug, I gotta piss.
Next Thursday? Let me just check the shift schedule.
I'm Mitch Kushner. I need a storage bin too.
Sorry, hang on, we're a bit short-staffed. Hi, Mitch. Just in time for dinner.
Last January it was 10. Last month it was 33.
It's crazy. Wasn't there a safe consumption site going on?
Oh yeah. That was pre-COVID. Things change.
No lobster today?
Sorry, we're not a 5-star hotel, man. But you know what? You close your eyes and pretend.
Vegetarian?
You bet. And enjoy.
Can't eat this shit, man.
Come on, Bobby. We serve what we get.
Diabetic, it's too many carbs.
Hey man, just eat what you can, okay? We can't cater to everyone's dietary preferences.
Hey, the damn food bug. What, no steak?
Not today.
When's your shift done?
Which one? It's a double tonight.
Just sleep.
I gotta get my car fixed. It's making that grinding sound.
That again? That car.
Well, at least mine is one color.
Okay, let's keep Audrey out of this. Hey, how's the new girl doing?
Same as the rest of us.
Sorry, when is that being delivered? Okay, so that's day shift. Nolan, I think.
Hey, can I get my insulin?
Yep. Yeah, can do. I will leave him a note. Okay, thanks. Hi, Bobby, right? What did you need?
Insulin? The yellow pen?
Oh, right. One sec.
It's supposed to take it before dinner.
Okay, just take more.
It's not. Never mind.
Sorry, we're not medically trained. Sunny Hill Emergency Shelter. Please hold.
Shower's open?
Yeah, check with Claire in the back. Yeah, miss, you can't bring that in here.
I'm kidding, man. It's empty.
No, I can't let you in with that.
Fine. They're empty, though.
How much have you had to drink tonight?
I haven't.
Have a good night.
That's awesome. And then he just walks away? Okay.
Oh, it's Dad. I'm just doing a welfare check. You doing okay?
All there. All there.
Oh.
Hey, Bobby. Wants to drink tonight?
No. It's just,
Come on. Let's sleep it off. Okay?
Sugar.
Straight to bed, okay? Hey,
Hi.
how are you adjusting?
Okay.
It's a lot?
Yeah.
Yeah.
Shorts.
Yep. Do the best we can, right?
Yeah.
Hey, when you go on break, would you mind doing a bathroom check on your way?
Yeah, no problem. I swear to God, if you're calling about something you can find on our website. Sunny Hill Emergency Shelter. Yes, we are 24/7. You can find all of that on our website. Thank you. Bye-bye. Now check, email staff. Hey, you good?
Email staff, good.
Hey, you okay in there? Hey, Bobby? Bobby? Shit, Robert, where are you? This is Annika in the men's bathroom. I have a medical emergency. Someone's out. Over.
I'm back. I'm on my way.
Hey, it's Sunny Hill Shelter. We have a medical emergency. Got a drug poisoning incident.
I'm here. With the person right now. 1, 2, 3. Miss, are you with the person right now?
Yes.
Naloxone?
Yeah, I just gave him naloxone. Like, hurts.
Is he conscious?
Bobby? No, he's not conscious.
Is he breathing?
Yes, he has a pulse. He was drunk before.
No, bug doesn't drink.
No, I smelled it on him earlier.
Does he have any medical conditions?
Shit. He has diabetes.
But I gave him his insulin tonight.
The ambulance is on the way.
You're coming first, right, Annika? He's having a seizure.
Diabetes. Diabetes sucks.
Well, my experience with diabetes was a rough one because I'm dealing with mental illness and addictions. So when I was in the shelters, I struggled with my diabetes.
Very difficult, very hard to cope with everyday things.
Being homeless, I mean, you're on, I don't know, I'll speak for myself. I was on guard like constantly.
Trying to manage your diabetes and trying to successfully get out of a horrible situation that no one should be in. Like I struggled, man. Like,
yeah, it's just another thing to have to worry about.
It's just a accumulation of like shit that hits you all at once.
Diabetes has caused me a great amount of bad self-talk and depression. It is a trigger for so many other things.
Got to the point because my sugars were high, wasn't thinking right, was sleeping all the time. I didn't want to live no more. So I left the shelter and I tried to commit suicide. Then you got all kinds of supports. But is that what it's got to come to? Me trying to commit suicide to get help? I mean, that's what it came to, right?
Diabetes is a chronic disease that affects people when their body, their pancreas specifically, isn't able to make enough insulin to keep their blood sugars in check. Diabetes isn't easy for anybody to manage. I tell my patients that they need to watch what they eat and they need to eat a very specific prescribed diet most of the time. Many times need to take insulin multiple times a day. We're talking 4 or 5 times a day, insulin injections. They need to monitor their sugars and do finger pokes and other things, calculate how much insulin they need to take. Take all of those things that your doctor is asking you to do and do that while you're dealing with incredibly difficult situations when you don't have a home. There's so many different layers of difficulty that people face, and it results in higher rates of complications and higher rates of mortality in this population in particular.
I have physically caused myself harm because it was too much to handle. Taking a needle every time I eat, having to check my sugars multiple times a day.
People see me taking insulin, right, and they would come up to me and ask me for drugs because they thought I was shooting drugs into my stomach.
And I made sure, first of all, no one saw that I had medications. And I always took them like where nobody could see me take them. I don't want people to think that I'm sick. I don't want people to think that I'm vulnerable.
Each shelter is different that I went to. Like usually they either keep it in nurse's office in the fridge or they keep it behind the counter. So because it has needles and it can be dangerous, whatever. So it's hard to access when you really need it.
One of the biggest angles for me that I want to stress is the food. Well, with the shelter, and I totally get it, like it's all high carbs because it's cheap, obviously, because you're feeding large amounts of people, like 200-300 people, right? And I asked them, could I get, better meals because I'm a diabetic? And they just said they can't do that. So my sugars were always high.
So hyperglycemia means high blood sugars, essentially. And so that happens when people's blood sugars are too high because they don't have enough of the medications or insulin that their body is making to keep their sugars in a normal range. And it gives people a fruity kind of odor on their breath when they're starting to have ketosis. And sometimes that can be misconstrued as alcohol on somebody's breath.
I had high blood sugars and my breath stunk, whatever, and then they kicked me out of the shelter for that because they thought I was drunk.
I've been in a shelter, I've been kicked out because I've had a low or a high.
I tend to look a little like I'm drunk when I'm high.
I'm really moody, I'm dizzy, and I want to sleep, and I pee lots.
Dry mouth. I'm tired.
I'm confused and delusional.
So usually I go somewhere safe in case I pass out.
One of the other complications when we're treating diabetes with the medicines that we use, either insulin or other medications, is that those medications are often meant to bring people's blood sugars back down. But sometimes if we've given people too much medicine or if they haven't done the things they need to bring it back up, like eating, then people's blood sugars can dip low. And that's even a bigger problem than when their sugars are high, actually.
When I'm low, like feels like I'm really drunk and probably Peter said I'm drunk.
Really shaky. Very distracted.
It's like a bubble vision and like shorter vision where I can't really focus on anything really.
People can become confused and drowsy. They start to feel very, very dizzy and can stumble. They start slurring their words and their speech and even have a seizure, which is when their brain is really, really unhappy and it starts to seize. So it's really, really serious when people's blood sugars are low and it can even be a fatal condition. I
went down 9 times like that within a month.
I joke around that I need to get a neon sign that blinks above my head that says that I am a type 1 diabetic. If it wasn't for the people that were around me that knew I was diabetic, I probably would have dropped like a fly. Everyone else thought I was just, one of the local drunks because I was stumbling.
I've had crazy shit happen. I got Narcan in 17 Ave Park because I collapsed with the opiate crisis and everything else. Their first instinct and thought is you're having an opiate overdose.
I no longer want to tell anyone that I'm diabetic. People look at me and they're like, well, you brought it on yourself. You ate too many, candy bars as a kid. Diabetes is not my life. I am not diabetes. I am a person who has diabetes.
It is, tiring to, continuously self-disclose that you have diabetes, or I don't blame people for not doing so, but then they're not getting the support that they need, right? Like shelter staff are not super eager to offer that support. But I mean, I get that too. Like these people they've got to be exhausted. What an exhausting job.
And a lot of it's not that they want to be that way or negligence. It's 300, 500 people in the shelter being able to distinguish what 25 of them are diabetic and like the special needs that they have.
Everything's looking good, Mr. Carter.
Is that my phone?
We didn't have one on you. Maybe back at Sunny Hill? How are you feeling?
Fine.
Well, you were pretty low.
Fine. Can I go?
Soon, Dr. Ovens will be coming here to discuss with you how you're managing your diabetes.
Not great, obviously.
You do have a visitor from the shelter, Annika.
Hey, new girl.
Can I let her in? Okay, Dr. Ovens will be right here. Bobby?
Hey. How are you feeling? my fault. I should have given you your insulin earlier. I looked it up.
I like talking about it.
Okay. It's weird that I'm here. Oh, I got your bag. It's in your locker.
But people judge me, okay? Everyone thinks they know better than me, or ignore it. They think it isn't real, or that I brought it on myself. Just have to keep explaining and explaining.
Well, could you explain it to me?
I hate it.
I don't even know what to ask. I got into this to help people.
Being homeless sucks. And you don't have diabetes.
Got any food?
Sorry, man.
Spare change?
Sorry.
I
Hey, Bug. Hey, Kevin.
How's it hanging?
Good. Can I get my insulin?
Sure. Just back in a sec. Hey, Annika, check his bag.
Bobby, Carter.
You bet. Let me get you signed in, Bobby. Welcome.
Can I get my insulin?
Yeah, just one sec. Sunny Hill Emergency Shelter.
Got any Penny?
Hey.
What? Seriously?
Yeah,
Penny?
the ambulance.
No.
You're good. Bobby, head on in.
Come on, Bug, I gotta piss.
Next Thursday, let me just check the shift schedule.
I'm Mitch Kushner. I need a storage bin too.
Sorry, hang on, we're just a bit short staffed.
Miley.
Hey, Bug.
How's it going?
You know, kind of living the dream.
New girl, huh?
Yeah. That's a crush on me. You got any tech?
Why does everyone think I have drugs?
Just asking. So that's a no?
No, man.
Don't be pissy, man. You want a juice box?
No,
Don't you have diabetes?
it's not how it works. Besides, I'm high right now anyways.
What?
Nothing. Sugar.
Yeah.
Not lobster today?
Sorry, we're not a 5-star hotel, man. But you know what? You close your eyes at 10.
Vegetarian?
You bet. And enjoy.
Can't eat this shit, man.
Come on, Bobby. We serve what we get.
I'm diabetic. It's too many carbs.
Hey, man, just eat what you can, okay? We can't cater to everyone's dietary preferences.
Eat the damn food, Bob. Right. Your steak?
Not today.
When's your shift done?
Just gonna stare at it.
Leave him alone, Mitch.
Lots of hungry folks out there. Just saying.
I have diabetes. I have to watch what I eat. Everything has too much sugar in it.
These are carbs, not sugar.
Carbs turn into sugar.
Wait. Don't diabetics need sugar?
My mom has diabetes. Usually she just gives me whatever she can eat.
Oh, wait, you want my dessert?
Since you're offering.
Look, I get it. It's hard being a diabetic. Just be thankful you're getting something.
Find something I can actually eat.
Grateful.
Excuse me, do you have any food?
No, sorry.
I have diabetes. I need to eat.
I can't help you, man. Sorry. When is that being delivered? Okay, so that's day shift.
Can I get my insulin?
Yep. Yeah, can do. I will leave him a note. Okay. Thanks. Hi, Bobby, right? What did you need?
Insulin? The yellow pen?
Oh, right.
So, supposed to take it before dinner.
Okay, just take more.
It's not. Never mind.
Sorry, we're not medically trained.
Didn't ask you to be.
Sunny Hill Emergency Shelter. Please hold.
Shower's open?
Yeah, check with Claire in the back. Miss, you can't bring that in here.
I'm kidding, man. It's empty.
No, I can't let you in with that.
Fine. They're empty, though.
How much have you had to drink tonight?
I haven't. How much did I eat? Close enough.
Oh, you say you didn't have any?
It's not tech, it's insulin.
Yeah, so you say. Heard about Cowboy?
Yeah, I heard about Cowboy.
Morning, man. Said everything's cut these days. You hang with the wrong crowd and
You gotta watch that stuff.
you want to talk?
It's not tech, man.
Yeah. In that case, bedtime.
Amanda, this is Kevin, and I need your support in the dorms.
Copy that. On my way.
Whoa! Hello. What? You sure? That's all. Be sure. I mean, hey. Hey, Pops. Want some drink tonight? Come on. Take it off. Me?
So yeah, there's like no one thing. It's just a huge part of my life every day, forever. Nobody gets it.
So what can we do?
I think that shelters need to have a little more medical knowledge.
In a situation like that, it would be good if the shelter staff would just listen to the person and really listen to what they're telling them, what their needs are in that moment, not just immediately go to judgment or assume the worst about them.
If there was a diabetic nurse in the shelter, I feel like they would keep track of who is diabetic to have that little push. Hey, Justin, it's just about dinner time. Go take your insulin.
If we got better options for food, it would work out a lot better for our sugar count.
You give them my insulin when I ask for it.
If I don't take my insulin before meals, the timing of my insulin and carbs is off. And that can make me go severely low later on. So when I say I need my insulin, I need it right now.
Maybe they could do a little research, figure out what are the basics, like what are the symptoms.
It's an impossible situation. We're not going to fix that problem tomorrow. But there are things we can do to help. I don't want us to be fatalistic either, right? To say, that's an impossible situation, I can't solve this. And I've seen that. I don't believe that either. I think that there's ways to approach that we can help over time.
Pause it there. After the film, we do find it's helpful for people to, kind of unpack some things they've seen and have a chance to interact with one of the co-researchers. So I've got Jeremy here, who you met in the movie. So just wondering if there's any questions for Jeremy. Maybe as you think, I'll start with the first question, Jeremy. Maybe you've got a room full of doctors who work in probably various areas of medicine. What would you like them to take away from the film, from kind of your experiences and those of your colleagues in the healthcare setting? Because the movie was focused on the shelter. What do you think is the applicable message here for doctors?
Just take a few seconds, I guess, to know what I'm saying or hear what I'm saying about like what's going on right at the moment. Like just listen.
Yeah, well said. I think Jeremy and his colleagues have often said that one of the things I see both in healthcare workers and shelter workers that we make assumptions and we often think we know what's going on rather than taking the time to listen. So I think that's great. Any other comments or questions? Anybody in the audience?
So what's happened as you made the film and started sharing it in different places? What kind of response has taken place?
Yeah, great question. Jeremy, do you want to talk about some of that? What are some of the things that we've seen happen because of it?
Like at the shelter, they have like a nursing staff there now. It's like more permanent, I guess. And there's other shelters that are like bringing like basic, like more healthier foods and stuff to their meetings and stuff like that, which is really good.
Yeah, so we've seen some policy change in shelters, which has been great. We have seen even individual level things. Somebody one of our colleagues actually brought their son to our very first screening. And it was pretty cool. A week later, he found somebody who was passed out on the street and normally would have just walked by and talked to the person and found out the person was actually having a low. And went and got a juice box and treated this person's hypoglycemic event. And this is a 20-year-old kid who said he never would have thought about that before. He would have just walked on right on by, but it was textbook from the movie, and probably saved somebody's life that day. So I think we've heard a few examples like that. I mean, there are other things that people have made donations to the homeless shelter after having seen the movie. Our local shelter after our initial screening received a big private donation from somebody who was in the audience, and I think it's mobilized people into wanting to help and kind of sensitizing them to the issues that people in our community are facing. Questions? Yeah, the back.
Present in the shelter is an excellent idea.
Yeah.
Are there plans to implement this in the future?
Yeah, good question. Jeremy, maybe you could speak from your perspective first. When you stayed in the shelters in Calgary, did they have anybody with any degree of diabetes expertise there to help you?
Not really, no.
Yeah. So like, do they have medical teams in the shelter you stayed at?
One shelter had a medical team, but they weren't specialized in like diabetes. They were just like a normal nurse that was just there.
And were they helpful when you had diabetes related issues?
Sometimes and sometimes no.
Right. Right. So I can say the problem is we are expensive. Healthcare workers in general, nursing is a very expensive service that's offered. And the more specialized they are, the more expensive they get. What I can say is in Calgary, our biggest shelter, we have one shelter that has 400 or 500 beds. They actually have a funding line for a healthcare team. That's one Jeremy's talking about. But a lot of the shelters, and I don't know how it is in Vancouver, but many other shelters are small, 30 beds, 100 beds. And the shelter's operating on a very shoestring budget from the government and often doesn't have any flexible resources to think if you're going to hire a nurse even part-time to work, well, there's you need to come up with $50,000 from somewhere. So just the opportunity cost. So that's one thing that we see is that shelters, the way they're currently supported, it's not feasible for them to do that. So that's part of what we're trying to do is advocate for change on the ground, but also take this to funders and say, we need better supports for people and find a way to make these services available. Yeah, go ahead.
Maybe an idea just thought of maybe just anybody with a health condition that needs following and
Yeah.
the titrating with medication.
Yes.
Maybe we can pull them into a specific shelter.
Yes.
Instead of having multiple diabetes nurses, we can just have one at this specific shelter.
Yes, you're absolutely right. And that's something I'm very interested in looking into. Actually, we started a program. There's a program called medical respite care in some homeless shelters. It was really pioneered in Boston. We had one in Calgary. We got one up and running right before the pandemic. And then it became a COVID unit and we've never been able to get it back off the ground. But the idea is when somebody's discharged from the CTU and they're either on antibiotics or they're just started on insulin new, like there's many medical conditions that we treat that need lots of titration and follow-up. And the shelter is ill-equipped to take care of those. But if you can put those people who need special medical follow-up in one place, you can get them the care they need. So there is a precedent for that. It needs the political will and the funding to make it happen, but it is something that we're looking into. And there are some really great examples of where they do that. Actually, in Toronto, I know they have a transitional housing program, kind of a group home specifically for people with diabetes. And they have diabetes supports there and they cook diabetes-friendly food. So there are models like that. They're just kind of few and far between. So you're absolutely right. I think that is a model that we need to look to. Thank you for that. Yeah.
What do you think would be most helpful as a person living with diabetes to help you take care of your diabetes in the setting of homelessness? Like, do you think it would be being able to carry your own insulin, to ask for it?
Yeah, I think because the shelters will take your insulin or your medications and put them aside for safekeeping. I honestly think that it'd be better. I would feel safer if it was on me at all times instead of having to run downstairs or go see a nurse or wait in line or something. I just think it'd be easier if I had it on me at all times. But most cases, that's not what you can do.
And she asked also about CGM. How do you think having a Libre has helped you or would have helped you when you were homeless?
When I was homeless, I used to go through like 50 strips in a day and it's like $1 strip. So this thing like updates like every minute and it's really helpful. Really, really helpful.
But I don't know how Libres are funded in BC, but in Alberta, they're not widely accessible for adults. For children, they are, but we have a hard time getting them on our public plan for adults. So yeah, it can be a game changer, as we all know, but unfortunately, as often is the case, the people who most need them have the poorest access to them. So.
Yeah, we've got adult funding in BC for
amazing.
people using multiple insulin doses.
Great.
So yeah, it's a benefit. So just mindful of time here because this is really great. Before going on to thank our speakers, I'll point out the next educational opportunity is the VGH Grand Rounds, which is Dr. Graham Wong and Division of Cardiology. So that's on December 5 at noon, evolution of antiplatelet guidelines. Just really want to thank our team, Jeremy, Dave, Tucker, for giving us the insight, giving us things to reflect upon, stuff that's really actionable in our day-to-day world within diabetes and indeed with all branches of medicine, because it's very extensible, I think, within the shelter community to all sorts of different types of things and kind of motivating us to think about next steps and also to express our gratitude for a really organized, inclusive approach to such an important problem. So again, thank you so much. and wish you all a good day. Take care.